Good morning. Welcome to Grand Rounds. Before introducing our speaker, I'd like to make a land acknowledgement. We're grateful to live and work on the traditional and ancestral and unceded territory of the Coast Salish people. This morning's Grand Round is on cardiac amyloidosis. Our presenter is Dr. Margot Davis, and we were just reacquainting ourselves with the fact that we worked together in 2009 when Margot was the chief medical resident here at St. Paul's. So as the former chief medical resident and as the three people in the audience, one of who is the new chief medical resident, welcome to Grand Rounds, Dr. Davis.
Thank you. Are there people on Zoom as well?
I would, yes.
Yeah, okay. All right, well, thank you so much for having me here today to speak. And it really is lovely to be here doing this based on all that history. So I am going to talk to you today about something that I'm very passionate about. So I'm really excited to have this opportunity to share it with you and hopefully collaborate with you all on the care of this patient population. I'm going to be talking to you today about the diagnosis and treatment of cardiac amyloidosis. And these are my disclosures. And these are my objectives. So I'm going to describe some approaches for the timely diagnosis of cardiac amyloidosis, outline and approach the diagnosis of AL versus ATTR, the two most common types of cardiac amyloid, and to discuss the efficacy and safety data of some exciting new therapeutic options that we have in this field. So if you leave this lecture today and really kind of forget about everything else that I said, these are kind of the key points that I really want you to kind of walk away with. Amyloid cardiomyopathy or cardiac amyloidosis is an underdiagnosed, it's out there everywhere and we just don't know about it, underdiagnosed cause of heart failure, arrhythmia, and death, especially in older men in the case of wild type ATTR and certain ethnic populations in the case of hereditary ATTR. It presents very non-specifically, which is why it's so underdiagnosed and why it's such a challenge. But it most often is going to present as heart failure, arrhythmias, and low flow, low gradient aortic stenosis. We can make the diagnosis one of two ways. In most patients now, we can diagnose cardiac amyloidosis non-invasively without the need for a biopsy of the heart or anything else, as long as you're able to rule out AL amyloidosis with some blood and urine tests. We'll talk about that more. However, there are a subset of patients in whom we can't rule out AL non-invasively, and those patients do still need tissue. And most importantly, this is a treatable disease. This is not the amyloid of 2009, where it was an untreatable disease that we, talk to people about palliative care and treat with diuretics and so forth. This is a treatable disease. We have good disease modifying therapy. We can change these people's outcomes, especially if we diagnose it early. So that's why it's so important. So just backing up then and looking at this more broadly, what is cardiac amyloidosis? Well, cardiac amyloidosis in general is really an umbrella term for disease where abnormal proteins from somewhere in the body are depositing somewhere where they shouldn't be with a specific fibrillar sort of structure. There are dozens of proteins that can cause amyloidosis of different types, and they all sort of behave differently. So when we're talking about the heart being involved, when we're talking about cardiac amyloidosis, we can narrow it down and eliminate most of those precursor proteins and types of amyloidosis, and know that the vast majority of cardiac amyloidosis is related to one of two precursor proteins. In AL amyloidosis, that protein that's depositing is a light chain, the light chain component of an immunoglobulin. And in transthyretin amyloidosis, it is, or ATTR, it is the transthyretin protein, which is a hepatic protein that carries retinol and retinol binding protein and thyroid hormone around the body. So hence transthyretin, also known as prealbumin. So you may have checked prealbumin on your patients to check their nutritional status. Prealbumin and transthyretin are the exact same thing, just two different names. Historically, so back in the day, AL amyloidosis was thought to be the most common type of cardiac amyloidosis, and it accounted for maybe 3/4 of all diagnosed cases. And ATTR was a much more rare, felt to be much more rare condition. Okay. But now in 2024, we know that this is actually all backwards, and that actually it's only because of the lack of diagnosis of ATTR that it seemed to be more rare. In fact, it's much, much more common, and the majority of new cases that we're seeing now are in fact ATTR. In the case of ATTR, there are actually two distinct types. That transthyretin protein can deposit in the heart and other tissues for one of two reasons. It can either be a mutant protein, in which case it has a slightly abnormal shape that makes it more prone to misfolding and depositing, or it can be a normally formed protein, non-mutant, wild type, in which case it tends to deposit just because it's an age-related condition. We don't totally understand why it happens to some people more than others, why that is much more common in men than in women, but it does appear to be a disease of aging in the case of wild type disease. And wild type disease is, of all the cardiac amyloidoses, by far the most common. Regardless of what type, they all have a very similar cardiac phenotype. They may have a different systemic phenotype. They have a very similar cardiac phenotype, which is sort of illustrated here on this echocardiogram here. They have these very thick walls, significant diastolic dysfunction, leading to a restrictive cardiomyopathy, which then, of course, leads to heart failure. So in the case of AL amyloidosis, I am a cardiologist, not a hematologist, so this is a cardiologist understanding of this, but essentially what you're dealing with what we're dealing with here is an underlying plasma cell clone. Now, plasma cell clones can behave in different ways. Sometimes they, reproduce in very large numbers and cause Crab symptoms, and then we call them myeloma. Sometimes plasma cell clones release a amyloidogenic light chain, which can then deposit in the tissues, and then we call it AL amyloid. And sometimes they do both, and then a patient can have both myeloma and AL amyloid at the same time. Those light chains, they form these first oligomers and then the amyloid fibrils, and they then can deposit pretty much anywhere in the body except for the central nervous system. And when they do that, they cause all kinds of problems. They deposit in the heart, of course, causing the typical amyloid cardiomyopathy manifestations. They can also deposit in the kidneys, causing nephrotic syndrome or renal failure. They can deposit in the soft tissues. They can deposit in the GI tract, causing all kinds of problems there, the lungs, so on and so forth. And the way that the AL or that the light chains cause the problems is actually twofold. So there's the actual direct fibril deposition, which leads to subsequent organ dysfunction, but they also have a direct tissue toxicity. And this is actually really important because this is how patients can respond to therapy. If you take a mouse heart and it's beating away and you take it out of the mouse and you continue to perfuse it, it'll continue to beat. If you then plunge it into a bucket full of fluid that has light chains from somebody with AL amyloid, it will almost immediately develop both systolic and diastolic dysfunction, both of which are reversible when you take it out of that bucket and put it back in a good bucket. So there's this sort of direct toxicity that accounts for a lot of the heart failure and cardiac dysfunction that we see in AL amyloidosis that is reversible if you can get the light chains under control with light chain directed therapy. So that's super important. Switching gears here, how does transthyretin amyloid happen? So I've told you already, transthyretin or prealbumin is a transport protein manufactured in the liver. It carries around thyroid hormone and retinol binding protein, transthyretin. It's produced in the liver as monomers, but can everybody just make sure they're muted, please? Thanks. So it's produced as monomers that then primarily circulate as homotetramers, and that's how they carry things around. But those tetramers exist in some degree of equilibrium with dimers, which then can also dissociate down into monomers. And it's the monomers that cause the mischief. So the monomers can then misfold and form these aggregates, and then the fibrils that can then deposit primarily in the heart, in the nerves, and in the soft tissues. And there they can cause peripheral neuropathy, autonomic neuropathy, and restrictive cardiomyopathy. Now, I've mentioned already this can happen because of a mutant protein that's more prone to that misfolding, the dissociation and misfolding, or it can happen with a wild type protein that just follows that sort of natural progression of dissociation to a lesser degree, but over time accumulates. In the case of hereditary disease, there are many, many different mutations that have been described, and it's super interesting because depending on the specific mutation, patients will fall somewhere on this spectrum from a pure cardiomyopathy phenotype to a pure peripheral autonomic neuropathy phenotype. So the V122I mutation, which is present in 3 to 4% of individuals of West African descent. So most African American populations would fall into that category. Afro-Caribbean populations, 3 to 4% of them carry this mutation. It doesn't have 100% penetrance, but when it does express itself, it is almost purely cardiomyopathy with much less, if any, neuropathy symptoms. The other end of the spectrum, we have the V30M mutation, which is otherwise known as the Portuguese mutation, also present in Swedish populations and Japanese populations. Don't ask me how that particular founder effect worked, but nonetheless, when this mutation occurs in Portuguese individuals living in Portugal, tends to present in people in their 30s with rapidly regressive polyneuropathy, fatal polyneuropathy, with minimal, if any, cardiac involvement. When family members of those Portuguese people who are living in Canada or the United States or wherever, carrying the same mutation that they inherited from the same ancestor, when they develop it, it tends to come on in their 50s with a mixed phenotype. Super interesting gene and environment interaction there, just kind of a fun little aside. Anyways, patients with hereditary disease, some of them will have very extensive cardiac involvement, some of them will have very little. How common is ATTR cardiomyopathy? Well, we don't really know because it's so underdiagnosed, because it presents so nonspecifically. But we do have some information from autopsy studies as well as from clinical studies. And so one of the sort of most classic prevalence studies that's quoted in ATTR amyloidosis is this autopsy study of individuals who died over age 80. So some of them died of heart disease, some of them were hit by buses, and some of them probably had prostate cancer. But they died of all causes. And when you look at their hearts under microscopes, 1 in 4 of them has transthyretin amyloid deposits present. Now, not all of them will be clinically significant. Some of them will have very small amounts of amyloid there that is not causing any trouble now. And had they lived another 10 years without being hit by a bus, then maybe they would have gone on to develop heart failure. But the important thing is that this is actually super common in people of a certain age. And if you looked at people in their 90s, it would be even more common than that. More informative is a study that was done on patients who were over age 75 with heart failure with preserved ejection fraction. And in those patients, 1 in 3 had these deposits. So these patients actually did have heart failure. They may not have died of it, but they did have heart failure. And 1 in 3 of them had ATTR deposits present in their hearts. So it's really, really common in older patients with heart failure, but we're missing it all the time. There was a study done of patients over age 60 who were admitted to hospital with heart failure, who had walls of greater than, I want to say, 11 millimeters. So modest increased thickness of their walls. And they did nuclear scintigraphy on these patients. So these are patients presenting with the clinical phenotype, and you're looking for imaging evidence of it. So you're no longer just looking for those microscopic deposits. In this situation, 13% of these individuals admitted to hospital with heart failure had imaging evidence of ATTR cardiomyopathy. So how many patients are admitted to CTU in a month who are over age 60 with heart failure, right? Now, how many of them are getting nuclear scintigraphy done? So great opportunity to probably pick up some misdiagnoses there. If you look at a TAVI clinic, 16% of patients referred for a transcatheter aortic valve replacement in one study had imaging evidence of ATTR amyloidosis. And if you look at an HCM clinic, hypertrophic cardiomyopathy clinic, lots of those patients are being misdiagnosed as HCM, when in fact, if you do the genetic testing, they don't have an HCM gene mutation, but they do have a positive pyrophosphate scan for ATTR. So they're out there, they're hiding in plain sight. It's our job to find them. What is the prognosis of ATTR cardiomyopathy? We don't have a great understanding yet of what the current prognosis is in the disease-modifying therapy era. So all of the data we have is from pre-tafamidis. But based on what we know from back then, the overall average survival of somebody who's diagnosed with ATTR cardiomyopathy is probably in the range of 4 to 5 years, although we can subgroup patients based on staging. So there is a staging system that incorporates GFR and NT-proBNP. If they're both really low or really good, I should say, then you have stage 1 disease. If they're both really bad, you have stage 3 disease. And if one's good and one's bad, you have stage 2 disease. And the median survival from diagnosis in a stage 1 patient is 6 years untreated. In a stage 2 patient is 4 years untreated, and stage 3 is 2 years untreated. So easy to remember, right? 2, 4, 6. So that's the prognosis, but we can change that prognosis with disease-modifying therapy. Prognosis in AL, when the heart is involved, is worse than in ATTR. And we know that untreated, a patient with AL cardiac involvement, so a stage 3 or 4 patient, is going to be in the range of 6 months. Now, great treatments have also become available in AL, and specifically daratumumab seems like it's really changing outcomes in this disease. And so patients can live a very, very long time. Even with CyBorD chemotherapy, I have many patients who have lived in excess of 7 or 8 years post-diagnosis, even some who presented in cardiogenic shock and thought they weren't going to make it. So again, early treatment, super important. So how do we diagnose cardiac amyloidosis? Well, we start with the so-called red flags, keeping in mind that these patients are presenting super non-specifically with heart failure and atrial fibrillation. How do we pick these needles out of the haystack? We look for these red flags. So heart failure with preserved ejection fraction in older individuals. So that's a very large pot, but that is sort of your first kind of big red flag to look at. So think about it. When you see HFpEF in an older patient, think, could this be amyloid cardiomyopathy? I should figure that out because I can treat them if it is. In particular, look for specific findings on their echo that suggest this could be ATTR. And the number one thing, most important thing, is the unexplained increased wall thickness. So a patient who has LVH, which is not LVH because it's not hypertrophy, it's protein deposits, but a patient who has LVH on their echo with no history of hypertension or severe aortic stenosis, why are those walls so thick? Think about testing that patient. There's other associated echo findings. In particular, we look at a measurement called global longitudinal strain, which is sort of an alternate measure of systolic function as an alternative to LVEF. And that is typically reduced in these patients with a very specific pattern where the apical segments of the ventricle still move well, apical sparing, whereas the mid and basal segments of the ventricle don't work as well. It's this very classic sort of bullseye or cherry on top pattern on strain imaging that echocardiographers are looking for. So you may see it reported at the bottom of your echo report. Abnormal strain with apical sparing, consider infiltrative heart disease such as amyloidosis. So that's something we're looking out for. MRI has some really useful findings. MRI is not quite ready to be a truly diagnostic test, although it's getting very close. For now, it's still a red flag test. But there are specific things, including increased extracellular volume, failure to null or inversion of nulling with gadolinium, and increased T1 signal that are increasingly specific for this disease and very sensitive for this disease. So if you have an MRI that's reporting any of these things, think about it. These patients, especially the ATTR patients, often will have bilateral carpal tunnel syndrome. They may have had surgery 10 years ago. That was perhaps their first indication that they had the disease. So bilateral carpal tunnel syndrome, very, very common in this population, as is lumbar spinal stenosis and biceps tendon rupture. I did an amyloid clinic one morning. I saw, I think, 8 patients, and 4 of them had a history of biceps tendon rupture. That is not the population norm, right? So very, very common, as well as other sort of soft tissue injuries, tendon ruptures, rotator cuff injuries, things like that are more increasingly common or more common in this population. And then finally, disproportionately elevated biomarkers. So the patient who comes in with heart failure, but they're only a little bit volume overloaded, but their NT-proBNP is 12,000, that's kind of weird, right? Or the patient who comes in and their troponin is 60, but they have no chest pain and no history of coronary disease, and it's just staying at 60. It's not going up and down. Think about amyloidosis in those patients. So once we identify these red flags, then we can enter the algorithm. And so there's lots of sort of published diagnostic algorithms for cardiac amyloidosis out there. This is the one from the Canadian Cardiovascular Society position statement on cardiac amyloidosis. And so what we do is we identify these patients using echo, MRI biomarkers, clinical findings. We find patients who have this phenotype, and what we need to do then is figure out whether or not we're going to go down the non-invasive pathway or the invasive pathway. And we do that by screening for AL amyloidosis. And this is really the first step in evaluating these patients. We do a serum protein electrophoresis with immunofixation, a urine protein electrophoresis with immunofixation, and a serum free light chain assay. The immunofixation is key. It's actually much, much, much more sensitive than the SPEP and the UPEP alone. And there are many patients who have a normal SPEP or UPEP, but have a monoclonal protein if you do the immunofixation. So it's actually super important to try and get those done. The labs, it can be hard to get it done in the lab. It does increase the burden on the lab. And so there is some pushback sometimes, but it really, it can be very helpful. And then the serum free light chain assay will give you a number for your kappa light chains, your lambda light chains, and there's a normal range for those. And if it's outside of that range, it suggests that there's a monoclonal element to your light chain abnormality. So if you screen for AL amyloidosis and everything is normal, so there's no sign of a monoclonal protein in the serum or the urine, then you've ruled out AL amyloidosis with greater than 99% accuracy. You can now go down the non-invasive route. You do not need to biopsy your patient's heart or any other part of them. And so then what we do is we send them for a technecian pyrophosphate scan. A technecian pyrophosphate scan is a nuclear scan. Technecian pyrophosphate was initially developed as a bone tracer. So it was used for bone scans, and then they found better tracers for that. But it lights up with ATTR, and I'll show you some pictures of that in a minute. But it's a very useful test when it's done correctly with sensitivity and specificity that approach 100% in patients in whom AL has been ruled out. And so if you do the pyrophosphate scanner and it's positive, then your patient has ATTR cardiomyopathy once you've ruled out AL. And then you just need to do a genetic test and figure out whether it's hereditary or wild type. If you do the pyrophosphate scan and it's negative and you've ruled out AL, then the patient doesn't have amyloidosis and you can carry on doing all the other things you want to do with your patient. So it's a really straightforward little algorithm for those patients in whom you can rule it out non-invasively. Now, if you do find evidence of monoclonal protein on your serum and your urine screen, then the specificity of the pyrophosphate scan goes down quite a bit. It goes down to about 86%. There are false positives on the pyrophosphate scan due to AL. About 20% of patients with AL will have a positive pyrophosphate scan. So if you can't rule it out, then the pyrophosphate scan is no longer a particularly useful test, because simply having a positive pyrophosphate scan, but not knowing if it's AL or ATTR, leaves you in a bit of a bind because the treatments are very different for the two diseases. So you really need some tissue at this point. So don't waste your time and the system's money on a pyrophosphate scan now. Go on and get a biopsy. You need tissue. Usually we recommend going for the affected organ because your diagnostic yield is going to be highest. If a patient is presenting with heart failure and thick walls, and you're wondering if there's amyloid in their heart, biopsying the heart is going to give you the most direct answer to that question. Because a patient who has cardiac amyloidosis may not have amyloid in their abdominal fat pad, they may not have amyloid in their bone marrow. And if you get a negative result on any other biopsy, then it's not necessarily very helpful. So I always say go for the affected organ. Endomyocardial biopsy is actually not a particularly big deal. I always tell my patients that, when a patient has a heart transplant, they're getting weekly biopsies for the first several weeks, and then every other week biopsies after that for a while, right? So it's a pretty routine procedure, especially at a transplant center like St. Paul's. And we go ahead and do that, and probably about 25% of patients still need a biopsy. Now, if you have tissue from somewhere else showing amyloid, then you don't need to biopsy the heart. So if you have a kidney biopsy or a fat pad biopsy or a lacrimal gland biopsy, whatever you've biopsied, and you have amyloid tissue there, then, and you have imaging that looks like the patient has cardiac amyloid, then you're done. You can make the diagnosis on that basis. But if you do the heart biopsy, you look at it under a microscope with some Congo red, and you see apple green with birefringent, blah, blah, blah. Then now you know the patient has amyloidosis. You still don't know what type it is. You need to send it away for some special testing. We send it up to the Mayo Clinic. They do mass spectroscopy there, and it will tell you what the protein is. And then you've made your diagnosis. So clear as mud, that's how we diagnose cardiac amyloid. Most of the time it's actually super straightforward. The key is getting those AL tests done. So I've got a patient case to go through with you guys to kind of illustrate sort of how we're doing things here. So this is a real guy, 74-year-old man, referred to the cardiac amyloid clinic a few years ago with possible amyloidosis after he presented with new onset heart failure and atrial flutter. So he has a past medical history of heart failure with preserved ejection fraction. EF is 50%. He has atypical atrial flutter or atrial fib with previous cardioversions. He's got bilateral carpal tunnel syndrome, and he's had carpal tunnel release surgery. He's got lumbar spinal stenosis, BPH, and osteoarthritis. And he comes to you on metoprolol 50 BID, apixaban 5 BID, furosemide 20, and pantoprazole. He's reports NYHA class 3 symptoms when you meet him. Blood pressure and heart rate are both pretty fine, but he's volume overloaded on physical examination. So we do some investigations. And so the echo is really small on the screen here, but you can hopefully appreciate that the LV size is normal, which is very classic in amyloidosis. These patients don't dilate. So normal LV size with quite thick walls. The septum measures 16 millimeters, which is 6 or 7 millimeters more than it ought to be. Ejection fraction is relatively preserved, but he's got that reduced global longitudinal strain at negative 11%. Negative 18 or more negative would be normal, with that apical sparing pattern and some moderate aortic stenosis. NT-proBNP is quite elevated at 4,000, and troponin is mildly elevated. Kidney function is relatively preserved. And he's got this ECG here that, if you look closely, shows sort of an atypical atrial flutter pattern, as well as low voltages in the limb leads, and this sort of pseudo-infarct pattern, we call it, where it looks like this patient has had an anterior MI in the past, but in fact, he's got normal coronaries. Very common. So what tests should be ordered to confirm the diagnosis? I've got people in the room. What are we going to do? Come on, team. Perfect. So SPEP, UPEP with awesome, with immune fixation and serum free light chains. Well done. Good. Okay, so we're going to do it. And so his SPEP and UPEP with immune fixation come back normal. There's no monoclonal protein anywhere. And his kappa and light chain, kappa lambda are normal with a normal ratio of 1.6. So what next?
Code white, Gerard level 1, as2. Code white,
Sorry.
Gerard level 1, as2.
Yeah, we're gonna do a pyrophosphate scan, right? Okay, before I get there, I just wanted to point out one thing here on this slide here. This is from this really great paper that was published last year. But one of the things that they did is they refined those cutoffs for normal serum free light chain ratio based on GFR, because when your GFR drops, the ratio goes up because kappa light chains are cleared more slowly than lambda in the setting of renal dysfunction. So your ratio will go up. And so this actually gave new cutoffs for what's a normal ratio, which is super helpful because a lot of these patients have some element of renal dysfunction. So this guy, though, his were normal anyways. We're going to go on and do a pyrophosphate scan on him. And so this shows you what a pyrophosphate scan looks like. Ideally, very importantly, you get both planar images as well as SPECT images. And so you can see in the planar films at the top there, the red arrow highlights it nicely for you, I hope. You can see that the patient with ATTR, there's this sort of black area where their heart is, right? That's the radio tracer in that area. And then if you look at the SPECT images, you can see that the LV myocardium and to a lesser extent the RV myocardium are hot. So is the spine, because remember it's a bone-seeking radio tracer, and the ribs as well. But you can see that it's the myocardium that's hot there, right? And so that's a very positive scan. In contrast, next to this patient is a patient with AL cardiac amyloidosis. So on echo, these two patients would look identical. But on the pyrophosphate scan, you see no black on the planar films. And on the SPECT, you see the bone uptake, but you don't see anything else. So that's a negative scan. So it's really important that these tests be done with SPECT, and I'll show you why in a second. And it's really important, of course, as I said, that this test be applied to patients who AL has been ruled out in, because 10 to 20% of those AL patients will actually have a positive scan. That's not helpful. So this here is an example of a false positive. And you can see here this patient did have both planar films and SPECT. On the planar films, you'll see this looks a lot like that ATTR patient did on the last slide, where there's sort of that black or gray uptake in the region of the heart. But if you look on the SPECT images, the hot spot is actually the blood pool in the ventricle. The myocardium itself is not lighting up here. So you see the ribs, the spine, and then you see the blood in the LV and the RV that's lighting up there. And so we do see this sometimes in patients who have, for example, a dilated cardiomyopathy. It'll look like they have it.
Hey guys.
Mute, please, on
Hey,
Zoom. Zoom, mute, please. Thank you. You'll see that you'll see these patients who look like they have ATTR on the planar films, and we get referred these patients quite often. And then if we look at the SPECT images, we see that it's not real, which is nice for the patient. Now, of course, there are, as I mentioned, some cases where we do have to go to biopsy, and this here is just showing you kind of what it looks like. There's your apple green birefringence under a polarized light. Okay, so back to Mr. F. So he has, we've told you, normal AL screen is a pyrophosphate scan that's strongly positive. It's grade 3, grade 2 and 3 are positive. And so then we, of course, send him for genetic testing, and he has no mutation in the TTR gene. So what's his diagnosis? Wild type ATTR. Awesome. Good. Okay, so what are we going to do for him? So this again is from the Canadian position statement. This sort of is how I always think of the management of amyloid cardiomyopathy, is sort of two parallel tracks. So on one hand, we're going to treat the patient's symptoms. We're going to reduce their stroke risk. We're going to do all of this sort of supportive care, if you will, management of the disease sequelae. At the same time, on a parallel path, in patients where it's appropriate, we're going to be trying to actually stop the progression of the disease using disease-modifying therapy. And so in terms of the management of the cardiac sequelae, sort of key here, diuresis is super important. Of course, these patients are presenting with heart failure and they're often very volume overloaded. And so we diurese them typically with a combination of a loop diuretic and an MRA, plus or minus metolazone or a thiazide if they need it. We use conventional heart failure and rate controlling therapies cautiously, if at all. So beta blockers are not strictly contraindicated, but they make patients feel like crap. And so one of the first things that I do when I meet a new patient with cardiac amyloidosis is I try and de-prescribe their beta blocker. So I reduce the dose, I see what their heart rate does, I reduce the dose, I see what their heart rate does. I try and get rid of it altogether. And often if they need something for rate control for their atrial arrhythmias, I use amiodarone because it tends to be much better tolerated. This is 100% anecdotal, but I see it day after day after day after day in the amyloidosis clinic. I promise it's true. There's no randomized data to prove that it's true, but I promise it's true. So beta blockers are poorly tolerated. Calcium channel blockers, and specifically the non-dihydropyridines like verapamil and diltiazem, they actually bind to the amyloid fibrils in the heart. And so they can cause toxicity, local toxicity, even if you're not like overdosing the patient. And same with DIG. So DIG will bind to those amyloid fibrils in the heart as well and can cause localized DIG toxicity. So that sort of classic, all the presentations of DIG toxicity that you see with arrhythmias and so forth, even if they have normal DIG, serum DIG levels. So we tend to avoid DIG and the calcium channel blockers completely. We anticoagulate them if they have AFib and flutter. We use pacemakers if they need pacemakers by standard criteria. We use defibrillators in secondary prevention, but not typically in primary prevention because the data have shown that they're not very beneficial in that situation. And of course, we consider heart transplant in highly selected patients. So how about Mr. F? What are we going to do for him? Well, we've got a few opportunities to optimize his therapy because he comes to us on 50 BID of metoprolol. He's volume overloaded and he is anticoagulated. And so that's important. So these are non-randomized studies, kind of illustrating what I've just said. On the right-hand side, you'll see a study that came out of Seattle recently, looking at patients in whom the patients presenting on a beta blocker and whom it was either de-prescribed or continued, and outcomes were better in patients in whom the beta blockers were stopped. Non-randomized observational data, full of bias, but there you have it. On the left, you see more observational data looking at patients who were either managed with a rhythm control strategy or a rate control strategy for their atrial fibrillation in the context of ATTR. And most of the patients with the rhythm control strategy were receiving amiodarone. And you'll see that outcomes were actually better in patients who were receiving, for the most part, amiodarone compared to those who were receiving beta blockers. Again, super confounded. Not randomized data, hypothesis generating at best, but it really does, it illustrates what we're seeing in our clinical practice. What about ablation? This here is just to show that patients with very early stage disease, so stage 1 ATTR cardiomyopathy, for instance, these patients can actually do fairly well with ablation. Once they've got more advanced ATTR, then the AFib is just going to come back over and over again. I mentioned diuretics and specifically MRAs. I use a lot of spironolactone. I always have, partly because these patients end up on high doses of loop diuretics, and the MRA is a nice counter in terms of their potassium levels. But actually recently, this secondary analysis of the TopCat trial came out that kind of reinforces what I've been doing. And what this is, what they did so TopCat was an RCT of spironolactone versus placebo in patients with HFpEF. And so what they did was they looked at echoes for whom they were available. And they tried to identify the patients who might have had amyloid based on their wall thickness and their tissue Doppler measurements. Not the best gold standard for diagnosing amyloidosis, but that's what they did. And there you have it. And what they essentially found was that the benefit of MRAs in their cardiac amyloid subgroup was essentially identical to the benefit seen in the non-amyloid subgroup. The patients with amyloid did worse overall, but they did do better if they got the MRA. So this sort of reinforces it. And so we're pretty routinely using spironolactone in our patients. This here is just to illustrate how important it is to anticoagulate these patients. This is a study that was done of patients with amyloid versus those without amyloid who were referred for a cardioversion, a TE-guided cardioversion. And you can see here that many more patients with amyloid had their procedure canceled on the day of compared to those who didn't have amyloidosis. And the most common reason for cancellation was that they had thrombus, left atrial thrombus. And of the 13 patients who had thrombus on TE and were canceled, 2 of them had been on AFib for less than 48 hours. So they're not supposed to have thrombus yet. And 4 of them had an INR that was therapeutic for more than 4 weeks, for more than 3 weeks rather. So they're not supposed to have thrombus either. So these patients are very prone to developing thrombus in their left atrium. It can be very challenging once they develop it to get rid of it. I assure you, I've had patients who've been on like 6 different anticoagulants trying to get rid of it. But it's super important that we anticoagulate them unless they have a very clear contraindication to it. I'm going to skip over this, but TAVR works in these patients just as much as it works in patients who don't have ATTR. So back to our patient. So we reduces metoprolol initially to 25 BID, and his heart rate is still 89, which is a perfectly acceptable heart rate. For what it's worth, these patients, because they have these tiny little ventricles, they tend to feel better with slightly higher heart rates. So a patient like this, they're going to feel great with a heart rate of like 80 or 90, probably better than they would with a heart rate of 60 to 70. His Lasix is increased, add some spironolactone, he feels better. His GFR holds, and his NT-proBNP comes from 4,000 down to 2,300. So we're winning, yay. We go ahead and stop his metoprolol completely. And his average heart rate now is about 115 beats per minute on Holter. That's faster than we want it to be. So what should we do? I'll just, in the interest of time, tell you what we did. We put him on amio and low dose, maintenance dose, 100 milligrams a day. The risk of long-term side effects with amio is pretty low at that dose, but of course, recommend all the usual screening of, liver and thyroid and lungs and so forth. And on amio, his heart rate comes down to 80, and then he's still symptomatic though, so go ahead and send him for a cardioversion, a TE-guided cardioversion, and it's successful. So he carries on apixaban, and his symptoms have improved to NYHA class 2. So what else do we want to do for this guy? Well, we want to think about the other parallel track, right? Can we change the course of his disease? Because without disease-modifying therapy, this is a relentless, progressive disease that leads to a very unpleasant death in roughly 4 years, right? So we want to do what we can for him. So in terms of disease-modifying therapy for amyloid cardiomyopathy, first of all, it depends what type of amyloid they have. Of course, that's going to be different. And so in patients who have AL amyloidosis, the disease-modifying therapy is chemotherapy with or without stem cell rescue or autologous stem cell transplant. And this works. It certainly prolongs survival in patients with AL. I've included here for you, hang on a second. So there's that. Liver transplant. So liver transplant is almost of historical significance now. It used to be offered to patients who had hereditary ATTR because essentially the liver is producing the mutant protein in these patients. And so if you take that liver out and put one in that produces wild type ATTR, then they should stop laying down ATTR deposits. Sometimes it works, sometimes it doesn't. There's lots of interesting stuff to get into that on, depending on which mutation they carry, it's more like less likely to be beneficial. But the long and short of it is that liver transplant is a very morbid procedure. It has a lot of complications and outcomes are not amazing. And so if you can do something better than that, then let's do that. And so now in 2024, it's very rarely done because we have other disease-modifying therapy that doesn't require somebody to have major abdominal surgery and be on immunosuppressants the rest of their life. So what we're talking about now then in Canada, what's currently approved are tafamidis for hereditary or wild-type ATTR cardiomyopathy with NYHA class 1 to 3 symptoms, or the 2 silencer drugs that are currently available, and I'll talk about that in a second, inotersen and patisiran for patients with hereditary ATTR with ambulatory polyneuropathy symptoms. So these are not, just to be totally clear, these are Health Canada approved drugs. These are not experimental at all. So they're, make sure everybody knows that. So how do they work? So tafamidis, which is approved for cardiomyopathy, is what we call a stabilizer. So I always think of tafamidis as like a little claw that grabs onto that tetramer and holds the 4 monomers together so they can't dissociate apart from each other. And if you don't let them dissociate, then the monomers can't misfold and they can't form amyloid fibrils. And that works. Inotersen and patisiran work very differently. So they're the so-called silencers because they silence the gene. They prevent the translation of the TTR mRNA into the transthyretin protein. And they work slightly differently. One of them is a small interfering RNA and the other one is a antisense oligonucleotide. But at the end of the day, they do kind of the same thing. And in doing so, they reduce circulating transthyretin levels by about 70 to 80%. And that works too. So what do they actually do in the clinical setting? So tafamidis, the ATTRACT trial was published back in 2018, and it randomized 441 patients with ATTR cardiomyopathy to either tafamidis or placebo. And about 3/4 of them were wild type, 1/4 of them were hereditary. So both populations were studied. And it was incredible. So this was a disease that we used to palliate patients for, and all of a sudden there's this drug that reduced mortality by 30% and reduced cardiovascular hospitalizations by 32%. Number needed to treat to save a life over 2.5 years was 7.5. That's a really low number needed to treat. And if you look at like cardiology trials, it's really quite amazing. And so it did that, and with really no side effects either. It's very well tolerated drug. It also improved exercise tolerance measured on a 6-minute walk test, improved quality of life measured on KCCQ. So for that reason, like I said, in Canada, it's been approved and it's recommended in the guidelines for patients with NYHA class 1 to 3 heart failure due to ATTR cardiomyopathy. It was not studied in patients with class 4 symptoms. And interestingly, in the ATTRACT trial, patients with NYHA class 3 symptoms derived less benefit. And in fact, actually looked like they had more hospitalizations, but still had mortality benefit. And the argument there is that they lived longer and they had NYHA class 3 heart failure. So those patients are just sort of in and out of hospital a lot. It's still, like I said, still a reduced mortality, but less benefit, certainly with respect to hospitalizations. And so for that reason, actually, if you look at the European guidelines, ESC guidelines on the left there, they actually only recommend it for patients with NYHA class 1 or 2 disease. So Mr. F, does he meet criteria for tafamidis? Well, he has a 16 millimeter thick septum, which is one of the criteria. He has wild type ATTR, which is one of the criteria, and he has NYHA class 2 symptoms, which falls into one of the criteria. These are the prescribing criteria for tafamidis. So yes, he absolutely does. So what if he had hereditary ATTR with or without polyneuropathy symptoms? Well, then if we know that somebody has hereditary ATTR, this is why it's so important to do genetic testing. Because if you know somebody has hereditary ATTR, it actually opens up more options on the menu, right? So now we have other treatments that we could use instead of tafamidis. And those are specifically inotersen and patisiran. Inotersen and patisiran have so far only been approved for hereditary disease with polyneuropathy. They've not been approved for a cardiomyopathy indication. But in patients who do have the polyneuropathy, both patisiran and inotersen were shown to improve both neurologic impairment scores as well as quality of life in their respective RCTs that were also published in 2018. And so this here is patisiran. You can see here on the left, their neurologic impairment scores actually improving from baseline in the patisiran treated arm versus that progressive worsening that you see in the placebo treated arm. And inotersen, not actual improvement from baseline, but certainly much better off if they're treated than receiving placebo. So currently, these are our Health Canada approved disease modifying therapies. We've got our silencers, we've got our stabilizer, but this is such an exciting time in amyloidosis. I can't even tell you how exciting it is. So we've got acoramidis. So acoramidis was actually just published in the New England Journal, the attribute study, which randomized patients to this other stabilizer versus placebo. I'll talk a bit about that in a second. We've got two new silencers, eplontersen, which is sort of like next generation inotersen, and vutrisiran, which is next gen patisiran. And so these have both been studied in the polyneuropathy, hereditary polyneuropathy population, and they're effective and safe. And they have ongoing trials in the cardiomyopathy population. So that's going to be really exciting to have silencers hopefully available for our cardiomyopathy patients. And we have patients enrolled in here in the CardioTransform trial, which is the eplontersen trial. We also had patients in the acoramidis trial. This is super exciting. So CRISPR-Cas9 gene editing. So this introduces the possibility for a single one-time treatment that would edit the TTR gene in patients with hereditary or wild-type disease and just shut down TTR production for the rest of the patient's life in theory. So it's like a one-time silencer. And so this here is about to enter phase 3 trials. And then the holy grail of treating amyloidosis is the depleters. So drugs that can actually go into the tissues and get rid of the amyloid and potentially offer cure. So these are essentially monoclonal antibodies that bind to the fibrils and stimulate the complement system to initiate complement-mediated phagocytosis of the fibrils. And so there are two of these. One of them is in phase 2 trial right now. The Novo Nordisk drug is in phase 2 trials, and we actually have a bunch of patients enrolled in that trial. Super exciting. And then that's about to roll into a phase 3 trial. And there's also a phase 3 trial of Alexion / AstraZeneca's product. So there's a lot of obviously interest in the pharmaceutical world in these drugs. They're really big companies are investing a lot of money in this because they see the potential, because they know that there's so much of this disease out there. So that's super exciting. I want to leave a few minutes for questions, but I'll just kind of show you. This is the acoramidis one. This is the one that was just published last month. So the attribute study randomized patients to acoramidis or placebo. And it had a hierarchical endpoint, but you can see here that if you look at the hierarchical endpoint of death, cardiovascular hospitalization, NT-proBNP, and 6-minute walk test, which was their primary endpoint, it favored acoramidis significantly. And if you peeled things back and looked at the secondary hierarchical endpoint of just death and cardiovascular hospitalization, it was still significantly favored acoramidis. There was, however, not a significant difference in mortality with the acoramidis treated patients, although there was a trend with a relative risk reduction of 25%. Similarly, there was a non-significant trend with a 30% numerical reduction in cardiovascular mortality. Cardiovascular hospitalizations were significantly reduced by 50% in this population. And this is just to compare the acoramidis trial to the tafamidis trial. One of the reasons why there was probably not statistically significant difference in mortality in the acoramidis trial was that it was a different population that had much lower mortality overall. So the mortality in the placebo arm of the more recent trial was the same as the mortality in the treatment arm of the earlier trial. So there you go. Apollo B was a phase 3 trial of patisiran, the approved silencer in patients with cardiomyopathy, and it met its primary endpoint, which was a combination of 6-minute walk test and quality of life, although it showed no difference in hospitalizations or mortality, and so it's not approved for cardiomyopathy. But its baby, vutrisiran, like I said, is in trials right now in the Helios B trial. Eplontersen is in the CardioTransform trial, which I mentioned. And then I've kind of talked already a little bit about CRISPR-Cas9. This is a sort of phase 1 trial. I think it was 6 healthy volunteers, and it got published in the New England Journal. You have to have really exciting data to get published in the New England Journal with 6 patients. But you can see how exciting people would potentially find this. And then these are the depleters that I talked about. So in conclusion, please consider amyloid cardiomyopathy in your patients who are presenting with otherwise unexplained heart failure or arrhythmias. Supportive management has important nuances that differentiate it from management of other heart failure. And disease-modifying therapy is widely available, effective, and super exciting in terms of the pipeline there. So thank you. I would also like to just shout out, we just planned this last week. The date was just decided on last week, but the Canadian Amyloidosis Summit will be held in Toronto, October 18th to 20th. This is going to be both patients and clinicians and researchers all coming together for 2 days of both scientific talks as well as sort of networking and discussing, best practices for patients and their caregivers. And then I also just wanted to shout out that on February 28th, the UBC Division of Cardiology is hosting a Women in Cardiology evening for women in cardiology, but also any trainees, female trainees who are interested in cardiology. I'm sorry, men, we don't mean to be exclusive, but we do mean to be exclusive. We're trying to sort of bring everybody together for networking, mentoring, support, and so that we can explain to all of you how awesome it is to be a woman in cardiology. So please, I think you guys may have received the invite, but please feel free to reach out if you didn't and you're interested in joining us February 28th. So thank you. Welcome your questions.
Thanks, Margot. There may be people online that would like to ask questions, and I can't see anybody at this point. Is there anybody virtually that would like to ask Dr. Davis a question? And if not, I'll open the questions up to the audience. Any questions? Sorry.
Hello.
Hi, Margot. It's Stephen Parkin from VGH Hematology.
Hey, Stephen.
Hey, I was just wondering if you've heard of any preliminary data for the monoclonal antibodies, the depleters in ATTR. As you know, the results in AL amyloid have been a bit disappointing.
Yeah, so the phase 1 studies were done by the companies that developed them, and generally showed that they were safe. So not a huge myocarditis signal, which is of course the concern when you activate the immune system against the heart. So not a huge there, and certainly showed. Here I can. So this is Prothena's data, which is the one that was bought out by Novo Nordisk, and you can see here. Sorry, I have a new version of Java available. I don't want to do that. Sorry. So you can see here that so it first of all inhibits amyloid fibrils in a dose-dependent manner, which is important, of course. So it's going to clear it from the system before it deposits, as well as clearing the ones that are actually deposited. You can see here that it's binding to both hereditary and wild-type ATTR in the heart here, and with different mutations. And then here you can actually see the phagocytosis of the amyloid. So it's the number of cells that have internalized ATTR with the drug compared to the control. So I mean, this is preclinical data, but there are phase 1 studies as well showing that it's safe. So we've got patients in our phase 2 right now, so we'll hopefully have data for that very, very soon, because it's a short study. It's a 1-year study.
It's exciting. Okay, well, thanks for a great talk.
Thank you.
Any other questions from the audience? Well, I have a question. This frequency of amyloid in the heart, you said 1 in 3, 1 in 4?
Over age 80, 1 in 4, yeah.
In patients who have hypertensive disease, who have thickening, has that population been looked at prior to the age of 60 to decide if they have amyloid as part of their diastolic dysfunction? So
yeah, I would say I'm not aware of studies in younger patients like that. Most studies have been in older patients. Okay. The only there are several studies looking at Black patients, because of course with the mutation that's present in African American and African Canadians, it's such a high prevalence, and the fact that hypertensive heart disease is so common in that population, there have been many studies that have kind of tried to look at that and understand it a little bit better. So for example, in the BEST trial, which is a bisoprolol trial from like the 90s or something, really old trial, but they looked at Black patients who were enrolled in that trial, and it wasn't cut off by age, and actually 10% of them carried the mutation. Yeah. So it's there in younger patients as well with heart failure, but it's just, I think, people are still trying to get the low hanging fruit. So focusing on the older populations for the most part.
Good, thank you. Any other questions from the audience? Yes.
I was just wondering, so you mentioned that patients that say an SFU and serum-free lead ratio working up for AL amyloidosis, and they don't get, because the lab always doesn't do the immunofixation, will those patients typically have an abnormal chain ratio, or is that not always?
So yeah, that's a great question. And Stephen can speak to that as well, perhaps. But Dr. Parkin, sorry. But if a patient has a normal SPEP, a normal UPEP, and truly normal serum-free light chain assay, the chances that you're going to find something on immunofixation are quite low, not zero. There are definitely AL patients out there in whom it's only found there, but it's about 1% of patients that you're going to pick up that way. So there's actually been a lot of discussions at the provincial lab level and trying to develop an algorithm for labs so that they'll start doing this for us when it's appropriate. And what we've decided on is that they'll start with the SPEP, the UPEP, and the serum free light chains. And if those are all completely normal, and I mean completely normal, because you know what, sometimes the SPEP or the UPEP, they report like the UPEP will be like glomerular proteinuria. That's not normal, right? So if they're completely normal, then they're going to stop and they're not going to do the immunofixation. But if there's an abnormality of any type on any of those, so even like an isolated mild kappa elevation, then they're supposed to do the immunofixation at that point. So, you know, we work in a resource limited environment, and we have to be, you know, thoughtful about where we're spending healthcare dollars. And so this was kind of a compromise that we've reached.
Any other comments or questions? Yes.
If you were to do a biopsy in the heart, is it possible to miss the amyloid?
Can you repeat?
Yeah, great question. So the question is, can biopsies of the heart miss it? And the answer is extraordinarily rarely. So you know, we talk about, for example, with cardiac sarcoid, which is this very patchy, you know, granulomas, and the diagnostic yield is 10% or less. With amyloid, it's a very diffuse process. And so the chances, if you're doing 4 biopsies, the chances that you're not going to get a sample with amyloid on it are extraordinarily rare. And if you do, then there's probably not clinically significant amyloid there.
Any other questions or comments?
I was just gonna ask one more.
Yeah.
You had a slide there about stenosis in patients with amyloid.
Yeah. I skipped over it. Sorry.
Probably a big topic, but what are some considerations for patients with amyloid experience?
Yeah. So that's a really great question, and you're right. Like, I have a whole slide deck on that question, but essentially, if you're going to consider offering somebody TAVR, then you would want to know that you can also offer them disease-modifying therapy. What I didn't say about tafamidis is it's effective and it's well tolerated, but it's extraordinarily expensive. To the tune of $200,000 a year is the list price. Like, it's really, it makes TAVI seem cheap, right? So the process to get access to that, most patients can access it if it's appropriate, either through their private insurance or through a program through the ministry called the Expensive Drugs for Rare Diseases program. But there's a whole application process that you have to go through. And so if you have a patient who they want to do TAVR, but they're not eligible for tafamidis because they don't meet the criteria, usually it's going to be because they have like a lot of other comorbidities or frailty, and it's not felt that tafamidis is really going to change the outcome. If you can't give them disease modifying therapy, it probably doesn't make sense to do their valve, and vice versa. If someone's too frail to have TAVR, then offering them disease modifying therapy probably doesn't make sense because they're going to die of their severe aortic stenosis. So it's really important to be able to treat both of them. So you have to make sure they kind of meet criteria for both. Having said that, most patients who don't meet criteria for one probably don't meet criteria for the other. Yeah.
Is it worthwhile to try to get like a random subcutaneous biopsy to try to diagnose before going to the cardiac biopsy, or like instead of safe?
Yeah. So the question is, if you suspect cardiac amyloid and you need to get tissue because you can't rule out AL, is it worth going for a non-cardiac biopsy first, just because it's less invasive, like a fat pad? I think if you asked 10 different amyloid specialists, you'd get several different, maybe not 10 different answers, but several different answers to that. Some people do advocate for doing, for example, a fat pad first, because in AL, the yield is actually quite high. In ATTR, the yield of fat pad is very low, but in AL, it is quite high. And I think the difference in answers to that is also to some extent informed by the practice environment you're in. It's really hard to get a fat pad in Vancouver. Whereas in some centers, it's super easy, like cardiologists are doing them themselves in clinic. So I think a lot has to do with that. Here in Vancouver, it is tough to organize, whereas a cardiac biopsy is really, really easy to organize, for me anyways. And so that just makes sense.
So just as a comment about amyloid being diagnosed by fat pad, in all of the years, and there are many years that I've been practicing, I've never been successful in having amyloid shown by fat pad. Now that's probably an exception, and maybe it's related to Vancouver, but just for that information. I don't know about the rest of you, but I learned a lot today about cardiac amyloidosis. I don't want to repeat it, but I want to thank Margot.
Thank you. Thanks so much for having me.
And just so you know,